Hello, everyone, and welcome to today's AFA Care Connection webinar. My name is Susan Shipman. I'm a social worker here at the Alzheimer's Foundation of America. The topic for today is challenging behaviors in people with dementia. We are very fortunate today to welcome back as our guest speaker, Dr. Linda ERCOLI. Dr. ERCOLI will talk about the types of challenging behaviors that occur in people with Alzheimer's disease and related dementias, the impact of those behaviors on caregivers, and evidence-based strategies to reduce those behaviors. But before we get started, just a couple of housekeeping issues. All the lines are muted, but we of course encourage questions, so please feel free to use the question box during the presentation, and if there's time, we'll have a brief Q&A at the end of the webinar. Any questions you have for the Alzheimer's Foundation of America, I will include our contact information in the wrap-up email I'll send you, along with your certificate of attendance. Also, Dr. ERCOLI has generously offered to provide a copy of her presentation and her website contact information. All that said, let's get started. Linda ERCOLI is a geriatric psychologist with a specialty in neuropsychology and caregiver stress and education. She has collaborated on numerous research studies of the early detection of dementia, interventions for cognitive impairment, cognitive enhancement programs, caregiver stress, and senior mental health. She has worked extensively with families caring for people with Alzheimer's disease and related dementias. She is the interim director of the UCLA Longevity Center. And now I'll turn the talk over to Dr. Linda ERCOLI. Welcome back, Dr. ERCOLI.
Thank you. Thank you, Susan. It's so good to be here again. And thank you to the Alzheimer's Foundation of America for the opportunity to talk to you today about challenging behaviors in people with dementia. This is such a major issue for caregivers, and I'm happy to be able to talk to you about, as Susan Shipman was saying, the kinds of behaviors that you may encounter and what to do about them if you are encountering those sometimes troubling behaviors. So just please realize as you're listening to this talk today that your loved one can't help or may not even realize what they're doing. They can't change. So these behavior problems that we'll be talking about, a good way to think about them is the way they can communicate now, because so many people have lost their ability to verbally communicate or communicate concisely or even form, concepts of what they're trying to say. So it's the caregivers that generally need to change or problem solve. And we're going to talk about how do I do that? So educate yourself about dementia, be aware of your actions, and lower your expectations of yourself and of your loved ones. Forget about perfection. This is really on the job training, real-time problem solving. And also try to think about if what you're encountering is really a problem for you, for your loved one, or for both of you. So these are some common behavioral problems in people with dementia. And I'm sure many of you have encountered some or even most of these. So asking repeated questions, wandering, being agitated, which is not being able to sit still or relax, or even being aggressive, having hallucinations, right? Seeing things, hearing things that aren't there, not cooperating. So maybe refusing to take a medication, refusing to take a shower, sleep problems, sexually inappropriate behaviors, sundowning, which is when people get confused as the sun starts to go down, withdrawal and isolation, right? Not wanting to be with others, not wanting to do things, and incontinence. So that could be it could either be fecal or urinary, that people just don't know when they have to go to the bathroom anymore and just may go and they can't control it. Now, what causes these behaviors? Well, different things. And this is where we have to change our thinking, because things that may bother your loved one with dementia may not bother you and may not have bothered them in the past, but they do now. So what happens? Well, let's talk about inability to communicate. Again, people have difficulty either directly with language. Some people lose their ability to speak. Some people lose their ability to think. And so they can't convey what they need or want in the moment. A difficulty with doing a task, something that maybe they've done with ease before. And so this brings about frustration and sometimes acting out. Being in strange and unfamiliar surroundings. So an example of this is somebody takes their loved one on a trip and they're easy to deal with at home. But then when they get to where they're going, they see agitation, restlessness, anxiety, insecurity, and it's coming from being in a familiar place, in an unfamiliar place. Now, another is loud noises. So what's going on in the environment, right? Loud noises, frantic environment, chaos. And to you, it may not be, but it could be having violent TV shows going on in the background, could have people coming and going a lot, could be strangers that maybe somebody's not strange to you, but it's a stranger to them coming in and out of your house. And it could be physical discomfort. And that could be environmental, or it could be internal. So environmental could be it's too hot, it's too cold, right? Internal, they're hungry, they have pain, and they can't communicate this to you and in the typical way. So this may create these behavior problems that you're encountering. Also, another important consideration is the relationship between the caregiver and the care recipient, right? What's your relationship? Are you getting frustrated with them? Is it antagonistic? Do they not recognize you anymore? And so they're pretending, it's not even pretending. You think they're pretending, but they're saying like, I don't know you. Who are you? You're not my daughter. And these kinds of relationship issues also can result in uncomfortable exchanges, opposition to being helped. So your relationship with the person you're caring for is also a big factor in triggering behavior problems and resolving them. So what do you do though? How do you deal with this? Well, you have to be a bit of a detective. So think of the goal as reducing the problematic behavior. You may not be able to totally eliminate it. That's what I mean by lowering your expectations. But the idea would be to reduce it in frequency or severity. And you have to identify what is triggering or setting off a problem behavior. And sometimes it's obvious. And like we say, sometimes if you go back to those causes, it's not obvious. It could be pain, it could be hunger, it could be having to use the bathroom. Identify what reinforces or rewards the behavior. So sometimes things that we do as caregivers or whatever the outcome of that problem behavior is may actually keep it going. So often modifying how you respond to a problem behavior is what has to happen in order to sort of reduce that behavior. So to try to figure these out, you get some ideas about what could be happening, and then you develop a plan, and it's trial and error. Try something, change something in the environment, revise the plan as needed. There's no like necessarily recipe for doing this other than identifying what you think might be triggering the behavior, thinking about the outcome and whether what's happening in response to that behavior keeps that behavior going, and then try to develop a plan and try to implement that plan, see if it works, and revise the plan if it doesn't. Now, a trigger could be something that's internal or external to the person. So again, it could be the noise, unmet needs, frustration, fear. Maybe they're not feeling well. The reinforcer, again, that's the consequences of a behavior that cause the behavior to continue. So here's an example. Somebody learns that your loved one learns that if they yell, then they don't have to take a shower. And what would be the reinforcer would be maybe the caregiver giving up, saying, okay, no shower. And it's okay to do that, in the moment to maybe take down the intensity of a situation. But at some point, they're going to need to take a shower or get a bath or somehow get clean. And so if the response all the time is walking away, then that patient, that loved one is going to learn that all I have to do is yell and I get out of taking a shower. So the reinforcer could be you walking away. Now, a caveat here is that if a behavior comes on suddenly, like it wasn't there yesterday, right? And it happens today, or it wasn't there a week ago, but now it's a problem. The cause could be medical, or it could be due to some kind of change in their routine or situation. So a common medical cause of a change in behavior, like confusion, restlessness, is a urinary tract infection. So if you see this abrupt change, that's what could be going on. In fact, a lot of caregivers go, you know what? All of a sudden, she's wandering. She's having to go to the bathroom all the time. I'm gonna call the doctor and get a urinalysis done. And often they're correct. Other things could be medication side effects. They could be having pain, or if they're having some kind of an infection, often from a UTI, they can become delirious, which means they can get confused. They can get aggressive quickly, right? So these are things to think about if you see a behavior that comes on suddenly. So it's very helpful to keep a behavioral log. So this is one that I put together, but you can make your own up, just as long as you are keeping track of what is the behavior that's happening. For example, are they wandering? Are they pacing? Are they cursing you? Right? Are they hiding in isolation? So what happens right before that? That often gives you a clue to what that trigger is. Who's involved? Is it always you? Does it seem to matter? And when is this happening? Like the time of day? Because again, this can give you clues to what could be setting off the behavior. And then keep track of what the consequence of that behavior is. So let's say that someone swears at you, okay, or they tell you to get out, and who is involved might be you. Okay, you're coming in to give them medicine. It's 8 a.m, and you say, time to take your pills. And they say, get the hell out of here. And what's the consequence of that? Maybe you look shocked. Maybe you get frustrated and cry. Maybe you say, okay, I'll get out of here. But that reaction can also be part of what keeps that behavior going. So try to keep a log of those kinds of things. So here's one. Let's say somebody wanders and they say, okay, I got to pick up the kids. This is someone who's, 80 years old, and they're basically reliving their past. I've got to pick up the kids. And so they open the front door to leave. So what time is it? Is it like, 2 in the afternoon, 3 in the afternoon, which would be when they would normally pick up those kids? And what happened right before? So if they're pacing and they're agitated, well, what's going on? So maybe there's a caregiver at your house and they're not paying attention to what's going on. If you have a hired caregiver, maybe they're texting at the time. And so what happened? So there's a number of things that this leads a clue to. right? One is definitely if they're saying they have to pick up their kids, they're thinking they're 40 years old now and their kids are still young. And they're simply just leaving to go pick them up at school. That's what the wandering's about. But you can see that they're pacing and they're agitated. Why? Are you keeping them busy enough so that they don't think about that at the time that they would normally pick up their kids? And so this required somebody to be giving them something to do and being ready for that to happen at 2 in the afternoon. Like you learn, okay, this is the time of day where, grandma starts to think about the kids and this is when she's more likely to wander. So a consequence would be to stop that behavior could be that you keep that person busy, that whoever the caregiver is there distracts them, maybe offers them a snack, and essentially changes the subject. So this would be one way to figure out what's going on and how to counter that behavior and reduce it or eliminate it. Now, there are some general nuts and bolts about managing behavioral problems. And this talk will be available to you in a recording, but think about these 5, you could call them caveats. I call them tools in your toolbox: prompting, reassurance, distracting, which we just talked about, or redirecting someone's attention to a different subject, exercise and other activities. So keeping people busy and keep your communication simple. Very important. And we're going to go into these. Prompting is encouraging someone who may not understand, they're not feeling sure, right? They're unsure, or they're called apathetic, which means they just don't seem to be real interested in doing something. So you can use encouraging statements, let's go, let's have some fun, gentle touch, right? Look at them, talk to them, eye contact, or use gestures to prompt somebody. So you could say, it's time to get up and have your favorite breakfast, or it's time to get up, let's have pancakes. Let's go for a walk. It's a beautiful day. But the idea is to encourage people, but not nag them, not rush them, and not make demands. That's how you're going to get pushback. Those could be triggers, right? Nagging, rushing, demanding, pressuring people could be triggers for a bad behavior. Reassurance is just really your human kindness, right? Calming somebody. Again, you can use a gentle touch if somebody is okay with that. Use a gentle tone of voice, make soothing statements, and also recognize the person's feelings and emotions. So if somebody, doesn't want to go to the doctor, I don't want to go, you can say, look, I know you're scared, but I'm here with you all the way. And then after that, we're going to go for ice cream. Your body language, your facial expression should also be reassuring. Try to match, right? I know you may not be feeling reassuring. You may be frustrated, but what you show to your loved one needs to be the reassuring side, including your body language and facial expression, because people are very good at reading you. People with dementia are good at reading people's emotions. The other is distraction. I had of a colleague that says, distraction is your friend. Keep people's minds off of worries and fears, right? It changes people's mindset. They forget about what they were worried about, angry about. They forget what they were resisting. Forms of distraction could be switching your activities, even just going into a different room of the house. It could be changing the subject, just talking about something else. And yeah, you can change it quickly. Or offer a snack, a drink, right? So again, You can change it quickly. You don't have to necessarily warm up to it. It's like somebody is resisting maybe taking a medication. Maybe they need to just go outside for 10 minutes, enjoy the sun, come back in and try again and get them out of that resisting mindset. Clear and simple communication. This means using one-step commands and demonstrate or assist if you need to. So one-step commands, if you are going to bathe someone, it's really a process, right? You have to help somebody undress. You have to have somebody help them into the shower. If they're having some physical problems, you're going to put warm water on them. You're going to soap them. So you tell them what's coming next. But what you wouldn't want to say is, we'll get undressed, then we'll go into the shower and you can wash off and then we'll dry you off. Too much. One thing at a time. They can't remember more than that typically, and they can't process all that information. And it's going to generate frustration or even worry and fear in someone. Again, use that encouraging tone of voice, touch, and body language. A big one is when somebody is asking you repeated questions and people go, you already asked me that. You already asked me that. That's the wrong thing to say, because the reason the person is asking you those questions is they have absolutely no memory that they already asked it. And so that just makes people feel bad and anxious. Another is in your communication, don't use baby talk. People know when they're being baby talked or when you're being condescending, and it doesn't go over. Make eye contact at eye level. So don't stand over somebody and talk down to them. That can be intimidating. It can be like you're superior to them. And again, if you're going to talk to somebody, sit down next to them on the couch and look them in the eye and talk to them. Okay, and also we already talked about telling people exactly what you're going to do next, step by step, and also allow extra time on tasks, right? If you know that you have a doctor's appointment at 3 p.m. that they do, maybe you need to start 2 hours ahead of time getting ready. Okay, back in the day when they weren't ill, you would need 45 minutes, but those days are gone. It takes people more time. And so this is something that, again, remember when we talked about you have to change yourself. You can't change your loved one. This is one of those things where you're changing yourself. You're going to start getting them ready 2 hours before or whatever you need, so as not to rush or pressure them. And keep people busy with a schedule of activities. First of all, people need fulfillment. Just because they have dementia, whether it's Alzheimer's or frontal temporal dementia, it doesn't mean that they still don't want to have a rich life. That they may not think I want to have a rich life, but they need a rich life. They need to feel satisfied, fulfilled, feel useful. People's self-esteem gets really affected when they can't do things anymore. So having people stay busy is good for them, and it's good for you too. Another is it reduces boredom and it distracts people who may be nervous and agitated. It creates healthy fatigue so that people will sleep better or fall asleep more easily later on. And it's cognitively stimulating. You want to engender some kind of satisfaction and social connection with other people. So it could be having a visitor, it could be having a FaceTime with someone, or it could be going to adult daycare. And also, these kinds of things help reduce sundowning, which is that confusion in the afternoon, trying to keep people busy during that time. And then modify these activities so that they're at the level of the individual, not too difficult and not too easy. Now that can be trial and error, but if you pick, like if people used to like doing puzzles, you don't want to give them a 1,000 piece jigsaw puzzle. It's too much. But you can get a puzzle with fewer pieces. And you can also get even those wooden block puzzles. It kind of depends on your loved one, like what their ability is. And again, this is trial and error. So these are examples of activities. Other cool things to do for your loved one is have like interesting things in the home or even outside the home, like a bird feeder near a window. Having fish, although you probably, depending on the person, if they have a tendency to touch things and even eat things, you would definitely want a covered fish tank, and they make them for folks that, you know, for kids too, right? So you can't stick your hand in there. Offer snacks. Again, ask someone to help you around the house. That's huge. So maybe it's folding napkins or setting the table, but don't get caught up in, you know, is the fork on the left? Is it on the right? Just accept what they give you. Again, you're not going for perfection. Finally, you can play games. Reminiscing is great because old memories are the ones that people often still have until maybe the very end. But they can talk about their childhood. They can, you know, another great way is to watch like old movies that maybe are 40 years old, but put on an old movie. If they like certain actors, they like certain singers, put on those shows and that music for them. Now let's talk about a few specific problems. One is refusal to take medication. This is quite common. So number one, prioritize important medicines. If somebody, you know, what medicines do you have to take? It could be medicines to lower your blood pressure. It could be medicines for pain, but there may be medicines or like vitamins that they really don't have to take. And so prioritize the most important ones. If you can't get your loved one to take, you know, 6 pills, what are the most important ones that they need to take? The second is to use liquid meds, or you can crush non-time released or non-enteric coated meds. So these are meds that, you know, if they're enteric coated, you can't crush them because then they're going to upset the stomach. And if they're time release, or, you know, these long acting meds, and you crush them, you're going to ruin that time release. So if you can crush them, put them in applesauce or pudding, yeah, hide them and make them taste good, right? So also people have trouble with swallowing. Many people, as well, first of all, with age, but especially with dementia, these swallowing apparatuses, especially as dementia progresses or with certain types of dementia, really do falter and they don't work as well anymore. So think about that. The refusal can be due to that too. So that's why liquid meds and applesauce, meds with applesauce and pudding go down much easier. We also call therapeutic fibs as useful. These are saying something that's not entirely true, but to get them to do something. But you may have to not be entirely truthful with someone, because for them to follow what you want them to do is good for them. Okay, it's important that they do it. So for example, if somebody doesn't want to take a med, you can write up a false doctor's note instructing them to take the medications, especially if it's a doctor that they know and they really respect. It's coming from that person, and so they may just follow that advice. But whatever you do, don't fight or argue. If you have to go away and come back in a few minutes, that's fine. But don't get into, you know, a contest with them. So therapeutic fibs are helpful in calming people down. Here's a time to use them. Like, where is my deceased spouse? Now, they may know a year ago that their spouse died, but they don't know now. They can't remember. So I've actually known the people to say, well, they're at the store right now, or, well, dad's gone fishing, or he's at work. and then distract them and they'll forget about it. So can you tell them they passed away? Yeah, you can. And but at some point, how many times can you tell someone that? And it may re-upset them every time you do. So it's something maybe good for them just to just tell them a little fib and like that, and then move on and change the subject. Another one is hallucinations. I saw someone peeking in my window. What do? Do you say, no, there's nobody out there? That is, again, possibly triggering an argument. So you can just go along with it and say, well, let me check. And you look out the window, no, there's nobody there, and then close the drapes or the blinds. Or you could even say, I called the police and I filed a report and they're going to patrol the neighborhood. I just checked all the locks on the doors. No worries, we are safe. So these are these little therapeutic fibs that you can do, because challenging someone's hallucination is not necessarily a good idea. It's better to reassure them. Now, if it's a mild hallucination, like, oh, look, there's a doggy over there, that's a harmless hallucination. There's really no need to go, no, there isn't. So I remember there was a patient with Parkinson's dementia, and she went into this whole story of, there's a dog there, and I was in the room, and she's like, oh, that's One-Eyed Joe. One-Eyed Joe. Oh, look. I go, where is he? She goes, oh, he's right here. Oh, yeah, he's cute. That's how you handle it. But don't necessarily correct the person. Just reassure them. Disinhibition is a big one. This is behaviors that are inappropriate. They could be things that people say that are hurtful. They could be cursing. They could be exposing themselves or making inappropriate comments to family or strangers. So what do you do in these situations? Well, first of all, don't take it personally. If somebody says, you're a bad son, you've always been a bad son. I know it's going to hurt. It hurts. And if you've had a contentious relationship with that person that you are now caring for, it's going to hurt worse. But they have no filter. They cannot decide what they should say and how they should avoid hurting someone. It just comes out of their mouth. And it's not necessarily that they ever believed it either. Some people can have complete personality change. That's never what they believe, but it's going to come out of their mouth because they're upset. So first of all, there's some things you can do. One is just to remain calm and don't get into an argument with them. Again, what's the trigger? It could be you're asking them to do something that they don't want to do. So, you can try a different approach, be more reassuring. You can come back in 3 minutes in those situations. If somebody is doing something really inappropriate and like exposing themselves, masturbating in public, and this happens, it can happen at home, it can happen in residential care. First of all, yeah, you do have to be firm in those cases, not embarrassing them or shaming somebody, but just say, look, you can't do this. There are other people around. If you want to do this, you have to go in your room to do this. So we're not, not necessarily saying you can't masturbate, but you're saying you can't do it here. And there are other things to do if you can't stop that behavior. There are clothes, for example, that button in the back and people can't take them off. So there are like actual garments that people can wear that sort of prevent that behavior. But again, distraction and keeping people busy is a good thing to do for sexually inappropriate behavior. People can be often depressed. They can be bored. They can be lonely. So, and that's how it comes out. Sleep problems are also common in people with dementia. Often in people with dementia, something happens to the sleep-wake cycle. People don't always know why, but they might have difficulty falling asleep, or they have broken sleep. So first of all, make sure the room is comfortable. It should be cool and dark and quiet, or you could put white noise on in the background. Another is to close the drapes so they don't see things and illusions, hallucinations that scare them. Create healthy fatigue during the day, exercise, keep them busy so they can sleep that night. Get morning sunlight so that it stimulates the release of sleep hormones later on in the day. And try to get them on a schedule. Same time to bed, same time to wake up every day, even if they didn't sleep well. You want to reset their biological clock and avoid long naps during the day. Long naps during the day are basically going to take away from that feeling or pressure to sleep later on in the evening. So if they want to take a 15 or 30-minute nap, that's fine, but no 2-hour naps. It's pretty common, by the way, in folks with dementia. And again, these are some of the things that, you can say, okay, how do I know if they have a sleep problem? Well, if they can't fall asleep, if it takes longer than 30 minutes to fall asleep, and if they're waking up in the middle of the night and can't get back to sleep, or if you're waking up at 4 in the morning and can't get back to sleep, and then you have folks that are sleeping during the day and up at night, so they're reversed, and nightmares. These are some of the sleep disturbances that you can observe. So again, watch out for caffeine intake, right? These are things that keep people awake. Alcohol, their sleep might get off schedule if they go out of town, go out on vacation, take a plane ride, just like us, right? Poor sleep hygiene, that has to do with, again, keeping the room cool, having a sleep schedule that's the same every day. We talked about daytime napping, lack of physical exercise. This is important. Immobility or prolonged periods in bed. So people really need to get up. Even if they have, even if they don't have much mobility, put them in a Barca lounger. You can move somebody into a recliner from bed, but laying in bed all day is not a good thing. Okay. And we pretty much got into all of that. So let's talk a little bit about agitation and aggression. All right. Now, these are big for a lot of people. In fact, a lot of these behavioral problems are what cause people to get placed into a residential care facility sooner rather than later. It's because the caregivers just get burned out and they can't deal with it. They can't problem solve anymore, right? They're tired, they're frustrated. And agitation and aggression are two very compelling behavioral problems that also result in someone getting placed in a facility. So agitation is just pacing, asking repeated questions, fidgeting, being restless and uneasy. Aggression is just an extreme form of agitation, and it can be physical, where people are threatening you, hitting, spitting, throwing, right, destroying property, and self-harm as well. And then it can be verbal, right, just being argumentative, irritable, verbal threats. Screaming is not considered aggression. Like if somebody is screaming in the middle of the night, or let's say they're in their room and they're screaming, that's not aggression. That means something. It's communication, usually an unmet need, or they're lonely, but that's not considered aggression. It's directed right towards themselves or to someone else or towards property. Triggers, it's the same triggers really that trigger all the other types of behavioral problems, right? Unmet needs, frustration, depression and anxiety, chaotic or disturbing environments. Again, TV shows, because people have a difficult time distinguishing fantasy from reality with dementia. Sometimes people who have PTSD can also become aggressive if they're, reliving something. And often that happens um, in people with dementia. Their PTSD may resurface or bad memories may resurface. And then the caregiver can be a trigger. What's the caregiver's behavior? How is the caregiver approaching the situation? And sometimes it's just somebody that the person with dementia doesn't like. So it may not even be, necessarily something that the caregiver is doing. But let's say you've hired a caregiver and they just don't like that person. Unfortunately, they can't just say this, think, oh, this person is here to do me good, right? They don't think that. They're just reacting to some thought or feeling that they have. So it also can happen when the loved one doesn't recognize the caregiver, and that happens. Who are you? Why are you in my house? Right? They could perceive care as a threat, and this happens a lot with care like personal hygiene, right? Toileting, bathing, and mind you that if somebody has a history of trauma, somebody who maybe was assaulted, raped, um, having touch and care may be triggering them. And sometimes it's also the gender of the person, right? The sex of the person who's taking care of them. If they were raped, they may not respond well to male caregivers. So these are things that can happen. The caregiver's attitude is upsetting to the person. So again, critical, confrontational. And we talked already about unresolved issues between the caregiver and the patient. In fact, I wish I had done a study when I was running this particular support group for like 8 years. I saw so many people in that group that came for help, and probably over half of them, over half, had a history of poor relationship with the person that they're now caring for. So in these cases, what do? Always introduce yourself as a caregiver. Hey, it's me. It's Linda, your daughter. Yeah, you might have to say that, right? Explain what's coming next. Reassure people again, same skills, right? Being calm. And if there's a specific caregiver that they don't want to deal with, you might have to change personnel. And if it's you, sometimes you might need to hire somebody to take kind of that interpersonal trigger out of the situation. Also, for someone who's aggressive, try to keep them calm in a relaxing environment, have familiar objects around them, right? Nice things that feel good to people. And of course, sometimes you just have to chill out and take a break, right? So leave for a few minutes and come back. Do not stay and get into an argument and escalate a situation. You can also ignore the behavior, but not the person. So if somebody swears at you, first ignore it and see what happens. Because sometimes that behavior will just go away because you're not reacting. There's no reaction. Okay. Immediately looking shocked and could reinforce the swearing. Okay, and the inappropriate behavior. I remember a scenario where there was a man and he was in a residential care facility, and he was probably not a very nice guy towards women. Okay, when he was younger, people knew that about him, and he would be very inappropriate with the young caregivers. So what did they do at the facility? They got an older woman who's kind of tough, had been doing the job for a long time, to work with him. And guess what? He didn't pull that stuff with her. So they changed the personnel. But that happened to be kind of what his modus operandi was. And always address what someone is feeling. Like, I can see you're scared. Don't worry. I'm here to help. So if somebody says, I don't want this, get away, you can say, look, I know this isn't your favorite thing. I hear you, but this is going to make you feel better. This is going to get rid of the pain that you're feeling right now. Same thing when when doing personal care. Try to steer away from the word shower or bath or bathe. Usually using a different word like let's get clean. For some reason, it just has a better it lands better with people. And this, for some reason, and nobody quite understands why, but a lot of people with dementia, they become afraid of going into the bathroom. And think about the bathroom, it's echoey, it's cold. So try to make the bathroom a nice place, right? You can put some lavender or some kind of aroma in there. Have it an ambiance that's pleasing and relaxing. And you could also make sure it's like warm, etc. And in a bathing situation, have the person help as much as possible. So you can give them, if they're capable of this, the handheld shower head. So don't just push them under the water. Get a handheld shower head and let them do as much of it as they can. And let them try to dress and undress themselves, but you can help. See if that helps them relax more. The other is respect their modesty. People, just because you're giving them a bath doesn't mean like they're okay with being naked in front of you. So try to cover people with a towel during bathing and bathe people in sections. You could even bathe somebody in a bathing suit, right? So that's another thing that is important to think about. Say what you're going to do next. Be flexible on the time of day. So someone may not want a bath at 8 in the morning, but they're okay with it at 4 in the afternoon. And keep in mind that bathing daily is not necessary. Providing sponge baths in between showers or baths are fine. So maybe twice a week, 3 times a week, but really they do not need to be, unless there's some medical reason, nobody needs to be in the shower every day. And think about the bathroom for safety, right? Having, again, handheld shower grab bars, especially in the bathroom, not the suction kind, but the bars that you go into a beam in the wall. And having a shower chair, non-slip mats, and same thing, raised toilet seat, or you can even have a commode, which is like a portable toilet that you can put at bedside. And that also is a good tool to have if someone has incontinence. So remember to lower your expectations, right? This is not about perfection. This is about, first of all, getting the things done that you need to get done. This is about making it easier on your loved one. It's about making it easier on you. Ask yourself if the behavior is their problem or my problem. Classic example, somebody wearing a sweatshirt with a stain. And you're like, you can't wear that. You have to go to the store. You're coming to the store with me. And you can't wear that sweatshirt with the stain on it. Yes, they can. It's not a big deal. Would they have done it when they weren't ill? I don't know. Maybe not. But now they don't see the importance of it. Another way around that is to have duplicates. So if they have a red sweatshirt that they like, and get them another one. And when that one has a stain on it, just give them the clean one and don't say anything. Slow down and allow more time for everything. Everything takes longer. And so that means that you may not be able to get as much in a day. You probably won't, but that's okay. Be flexible. Keep instructions short and simple. Use different ways to communicate. And remember about distraction is your friend. And try to remain calm and don't escalate a situation. So we have webinars and Susan is going to send that out to you in caregiver education videos that you can look at. Almost like we have like 19 of them about almost every type of behavior that's a problem. So thank you so much for your attention today. It's my pleasure to be here. And I know we have some time for Q&A. So
Yes.
I'm ready when you are, Susan.
Okay, thank you, Dr. ERCOLI.
Thank you.
That was really terrific. We do have some questions. One thing, and I know Dr. ERCOLI would join me in this. I want to thank all of you, because all of you who are on here today are caregivers, professional or non-professional, and you don't always get a thank you. So we always want to say thank you. It is the most difficult type of caregiving. And you always don't get a thanks for that. So also, many of our caregivers, who are themselves often medical and healthcare professionals, often say we just can't get it right when they call us. And your earlier comment about forgetting about perfection is one we can all benefit from. I may have mentioned this before on a webinar, but one of our medical providers who spoke for this webinar series, a neurologist, told me just before the webinar began that he thought he knew a lot about Alzheimer's disease and related dementias, but when he became a personal caregiver, he realized he knew nothing. Because when you care for someone personally on a one-to-one situation and not in a clinical situation, it became very different for this person. So I just wanted to share that. So the first question we have, actually we have two questions about UTIs. You mentioned UTIs and abrupt changes. A person is writing, my mother had a UTI, urinary tract infection, for weeks before the nursing home tested for it. She didn't complain of anything, but she just seemed to shut down. She stopped eating. She was weak. She is now back to more of herself now after the medication. How do I get them to recognize it faster next time? Are the symptoms different in people with Alzheimer's disease and related dementias? And the second question says, my wife keeps testing negative, but appears to have a UTI. Is that possible?
Well, let me take the first one first.
Okay.
Number one is that the communication between the nursing home and the caregiver, that sounds like that's where the breakdown is. Because if they're not calling you and saying your mom's, not been eating, how are you going to know what's going on? So I think that's the first area of communication. And maybe it's tough when when your loved one is in residential care, because residential care varies greatly in the attentiveness, the quality of care. It's very hard to know what's going on if you're actually not visiting, or even just giving a call, once a week, and finding out like who takes care of your mom there, or if they have a charge nurse or somebody to touch base with. So that's what I would recommend there. And then usually being a squeaky wheel is really important when your loved one is in residential care. You can also, tell them, like, the last time my mom, was like this, I mean, she had a UTI. Will you please check her for a UTI? So you may have to be the squeaky wheel. I'm sorry to say that, but I would recommend it, especially in this case where it was 3 weeks before somebody ran a urine analysis for your mom.
Okay. So be alert to a rapid change in symptoms.
Well, usually it's rapid, or there's just like this person is not being themselves. And so yeah, I mean, if they just kind of change overnight, or they start going on a certain trajectory, or showing a set of behaviors that is out of character for them, you definitely would want to check for the UTI. And it's not always, what we think. It could be that they're somnolent, they're tired, like you talked about, nauseous, because it's an infection, right? And at the second question, do people with Alzheimer's disease react differently? Well, they certainly have a more vulnerable brain, right? to
Mhm.
than somebody without Alzheimer's. So that's number one to think about. Number two, they can't tell you what their symptoms are. So people don't always know that they have a UTI, but there are some giveaway symptoms like frequent, urination, pain in the kidneys and in the lower back. Um, but they can't necessarily tell you that, or you may need to do some inquiring. So,
Mhm.
but I don't know if somebody can have a UTI and while they test negative. I don't know if we have any physicians here. I have not heard of it, but I'm
Okay.
not a physician. But
Okay.
what else could it be? Right?
Mhm.
That's
Right.
another thing to look at.
Okay, fair enough. This comes under the refusing to cooperate category. My father was diagnosed with mild cognitive impairment, MCI, over a year ago. He did not take well to this news. Recently, our family noticed more changes in his behavior, but he will not return to the doctor. How can we get him to go? He simply refuses. And this is a primary care physician he knows, let alone a specialist.
Yeah, that's really difficult. So if he had MCI, and it is a risk factor for dementia, uh, not everybody with MCI will develop dementia, but about half do over 4 years, um, or more than half actually. So what can you do? One would be to be very specific about what you're seeing as getting worse. Contact the doctor's office and see if they will make a phone call and say it's time for your appointment. So that's one thing. See if the office would call him, like send an email to the doctor. Hopefully, you have email contact. I see email over telephone, and because a lot of the times people can't call you back, or they won't. Or if you have a doctor that you feel will call you back, or just say, look, I'm worried about my dad. There's been a change in the last year. Can you put in for a consultation with the doctor, whether it be a phone call back or do it through email channel and see what they suggest. Maybe they'll have the office call and see if it comes from them. The other would be, it depends how cognitively challenged your loved one is, but this might be a time to set up send them a therapeutic fib letter that says it's time for your doctor's appointment. The other would be to have a heartfelt conversation with him, telling him that you're worried about his health. And I necessarily would not bring up cognition, because that is probably, what's scaring him to return. But just say, Dad, I'm concerned about you because of maybe these symptoms. Would you please go and, for me and see maybe there's a medicine or some therapy that they can give you to help with these symptoms. Those are things that you can try. But this is a tough position to be in.
Yes. Okay.
Mhm.
We have one about non cooperation with medication. You talked about a script from a prescription from the doctor saying, take the medication and here's what it's for. What if the medication is for dementia or agitation or anxiety or something like that? What can we do in that case?
Um, since it's a therapeutic fib, I would I would write that letter in that context, so you could tell them that this medicine is important to make them feel to make them feel better, maybe more calm. You can say it's going to give them more energy. You could say but if they don't realize that they have dementia, or maybe you can tell them it's going to help your memory, because lots of people want that, but just don't use the word dementia in there, whatever you do. And and you don't have to tell them the truth about what it's for. You just don't have to. You can say it's going to help you sleep better at night. It's going to make you happier. It's going to make you feel more relaxed. Those are probably ways to put it instead of using the medical term anxiety or dementia.
Okay, very good. We have one. How do you handle someone who continuously is collecting things? We doesn't use the word hoarding, collecting. We want to be able to have items and interactive stations. I'm not quite sure what that is, but we have a collector who goes about and picks up things, and we lose a lot of items throughout the day.
Well, where are they coming from? Because one thing is to limit their access to where those objects are coming from. So is somebody going out like to thrift stores and buying a bunch of stuff and coming home, or are they ordering stuff on Amazon, or what does that mean? Are they bringing in like knickknacks, free, free newspapers? I'm not quite sure, but one would be to try to limit their access to the source of collecting. The other is, do they know if you get rid of anything that they've collected? Will they notice it? Can you thin it out yourself and don't say anything? That would be another way that you can handle that. What is going to be hardest to get them to stop collecting on their own? I don't think they will. So I think you either have to eliminate, the best would be to eliminate the access to all these things that they're collecting, or cut it down, right? Limit it. And the other would be to thin out what they have, especially if they're losing things and it's not important, or these are things that, just pile up and they don't really even know what they have. I would remove some of it. Keep some, but remove it so the pile doesn't get higher and higher.
Okay, we've had a very generous person answer who is an MD regarding UTIs, saying
Thank
that
you.
a negative urine test would not be indication of a classical UTI, and they would want the person, the caregiver, to ask the facility what urine test was done. And there are a number of alternative diagnoses that could include cystitis, a yeast infection, could be related to diabetes or a type of vaginosis, STI, a lot of different things, but that there are a lot of areas that could be looked at. That I'm assuming the reason that he's writing these is because they present similarly. So that's excellent advice. Thank you so much.
Thank you. That's
That was
excellent.
very kind. We have unfortunately there are many more questions, but Dr. ERCOLI is going to provide the link to the UCLA site, so you'll have more information available. But we've come to the end of our time today. Thank you very much, Dr. ERCOLI, for your contribution of this informative and detailed presentation. And thank you to everyone who attended and for your thoughtful questions. Again, I'll be sending an email with a link to the presentation and recording when I receive it. Before we end, I want to encourage you to sign up for our next Care Connection webinar, Thursday, June 10th. Our guest speaker will be Dr. Nathaniel Chin, Medical Director of the Wisconsin Alzheimer's Disease Research Center. He's going to address mild cognitive impairment, MCI. What is it? And how does it relate to Alzheimer's disease and related neurocognitive disorders? So I hope you'll all be able to join us. Please take care, everyone, until next time. And thank you again, Dr. ERCOLI.
Thank you. Thank you to all the caregivers out there for doing what you're doing. And thank you to the Alzheimer's Foundation for everything you do. And especially you, Susan. Be well.
You're so kind. Thank you, Dr.
Okay.
ERCOLI.
Okay, take care.
Bye,
Bye-bye.
everyone.